There we go, the session is now being recorded. So just for the purposes of the recording, today's session is the reach and benefits of a digital intervention to improve physical activity in people with a musculoskeletal condition that was delivered during the COVID-19 pandemic in the UK. So what am I going to cover today? Well, firstly, I'm going to just give you a bit of background about who I am and what I do. And then I'll give you a background to this evaluation project, this research. I'll then go into the research aim, how the research evaluation was conducted, what we found, a discussion of those findings, presentation of the conclusions, what next, so what happens or what is happening following this evaluation, and then finally leaving time for questions, so quite a lot of time for questions at the end. So who am I? Well, I'm Justin Webb. I have been working in the field of public health for many years, both as a practitioner originally and as a researcher. So my former roles include working as the director for the Centre for Workplace and Community Health at St Mary's University College. And following that, I was a national engagement manager for Macmillan Cancer Support, leading on the charity's Healthy Lifestyles program as part of their head office team, designing interventions, evaluating those interventions and conducting research, particularly into long-term healthy lifestyle behaviour change to improve cancer outcomes such as fatigue and quality of life. I then joined London Met. I've been at London Met for 5 years now, just over 5 years, and I am the course leader for the Masters in Public Health at the university. So I guess my specialisms or my areas of interest, I'm a public health professional. My interest is in designing, developing and testing, as well as evaluating innovative evidence-based solutions to bring about change. I've worked both across the Public Health Commissioner and provider landscapes, both locally and nationally, working with local authorities, other charities, non-governmental organisations, as well as organisations like the NHS and Public Health England. And I'm an experienced educator as well, teaching on both the undergraduate and postgraduate courses at London Met, but also doing external training for volunteers and also healthcare professionals. My area of research interest matches my professional interest, is in that evaluation of evidence-based behaviour change interventions, and I use both qualitative and quantitative research methodologies. My PhD was in psychology from the University of Surrey, and before that I did a Masters in Public Health at the University of Hertfordshire. So a bit of background to this evaluation, this research project. So the evidence suggests that physical activity has many benefits for people with a musculoskeletal condition, such as pain reduction, improved physical function and mental well-being, and protection against other long-term conditions such as heart disease and diabetes. However, even before the impact of COVID-19, many people with a musculoskeletal condition in the UK were not active to the required levels, and almost a third were classified or would have been classified as completely inactive. So this evaluation involved working with a charity called Versus Arthritis. And they're a UK charity. They're the largest charity dedicated to supporting people with arthritis. It was launched in September 2018, following the merger of two leading arthritis charities in the UK, Arthritis Research UK and Arthritis Care, in November 2017. According to research, 18 million people in the UK are affected by arthritis, and Versus Arthritis work to help those people to remain active by funding research, campaigning and providing information for patients, the public and healthcare professionals. The charity is committed to supporting people with a musculoskeletal condition to be physically active at a level that is right for them, because, as I said, physical activity has been shown to lead to reductions in pain, reduce disability, and improve mental health and quality of life. The charity have invested in a wide range of activities in the recent years that encourage and support increasing uptake of physical activity. In 2019, they launched a dedicated physical activity program to address that holistically, and that was supported by a Sport England investment. Versus Arthritis commissioned London Metropolitan University to develop and implement an evaluation of that program, of the Versus Arthritis physical activity program, and to report on the findings. And this is how this research came about. So as part of their program, they developed a digital intervention called Let's Move with Leon. And we were commissioned in 2020, the end of 2020, and as part of the first phase of our evaluation, which runs over 3 years, we were commissioned to evaluate the Let's Move with Leon digital intervention. So Let's Move with Leon, you can see the web address on the top of your screen there, so it's available for you to look at should you want to. If we have time at the end, I will show you this in more detail. It's a 12-week, well, it's actually a 13-week exercise program. There are 12 pre-recorded YouTube exercise sessions and a getting started session that precedes that. Each one of those exercise sessions lasts between 30 and 45 minutes, and the details are sent weekly to people over email. So they sign up to the program, they get sent an introductory email and then a link to the video. So you can see all the videos, or a number of the videos, here on the left-hand side of the screen. So we have a video on mobility, movement for life, session 3, adaptation and exercise, going through lots of different areas around fitness programming, exercise programming, and what to do. In addition, they have access to a 35-page activity tracker, which takes them through each of these 13 weeks, which can be completed online as a PDF or downloaded and printed. They have access to an activity hub, which houses all the videos, which is what you're seeing on your screen here. And they also have access to an online community via Facebook, as well as an online forum via the Versus Arthritis webpage. So how was Let's Move with Leon developed? So interventions with a theoretical grounding stand the best chance of success. That's what evidence tells us. And Let's Move with Leon was developed using a theoretical grounding, a model called the behaviour change wheel. So anybody who's worked with me or who I've taught previously or worked with previously know that I've used the behaviour change wheel extensively in the development of interventions and the evaluation of interventions. The behaviour change wheel, which is what you're seeing on your screen, has 3 layers to it. And at the center there, the source of behaviour is the behavioural model that suggests that any behaviour is made up of 6 components, being psychological and physical capability, so the capability to do something, the opportunity to do something, the physical opportunity or the social opportunity, and then motivation to do something. So the reflective motivation, thinking about doing it, making a decision, or automatic motivation, our habits and our impulses. So it's possible to create a behavioral diagnosis, breaking down a particular behavior by those 3 areas, those in total 6 components, to identify what needs to change to, in this case, encourage people with a musculoskeletal condition to be physically active. Once that is done, the behaviour change wheel incorporates 3 stages to designing behaviour change interventions. Number 1 involves understanding the target behaviour, which I've just explained. Number 2 is then designing the intervention using the intervention functions which are in red on your screen. I would happily go through with people who are here today what each of those mean, maybe in a later conversation. But for today, I'm just giving a very quick overview of the behaviour change wheel, just to emphasize that the Let's Move with Leon program was developed using a theory, and I'll talk about the evidence that was used in just a second. But just very quickly, in terms of intervention functions, you can select an intervention function to bring about a change in a COMBI, capability, opportunity, motivation component. So for example, you could educate people to improve their psychological capability, or you could persuade people, or you could use modeling to improve people's reflective motivation, or you could train people, improve their skills, or improve their strength and stamina to improve their psychological capability. You could restructure the environment to increase social and physical opportunities. Following that, you've got the outer layer, which is the intervention delivery. How do you bring those intervention functions to life? Do you provide a service? Do you use a communications and marketing program? Do you use guidelines? And again, you follow a process where you come up with a behavioral diagnosis. You then use that behavioral diagnosis to evaluate which intervention functions you think will be most appropriate to bring about change. And once you've done that, you then think about the outer layer, the intervention delivery policy categories layer, to think about which of those grey categories on the outside are likely to be impactful at bringing those intervention functions to life. Now, once the pandemic hit and the resulting movement restrictions in the UK were enforced, the pace and intensity of intervention development of Let's Move with Leon increased, with a view to launch the intervention as quickly as possible. So Let's Move with Leon was launched on the 16th of September 2020. So I've given you a quick overview there of the behaviour change wheel. Just to tell you, the evidence that underpinned that and that supported the application of the behaviour change wheel. So to understand the target behaviour, informal face-to-face discussions took place in July, and this was conducted by the charity with 100 people with a musculoskeletal condition through support groups from across the UK, and from a Versus Arthritis volunteering conference held in Wales. Now, I did work with on a kind of a consultancy basis, the charity to help construct interview topic guides to begin to unpick, but the work was conducted by the charity, so this was their work. In addition, the Versus Arthritis online community was reviewed for mentions of exercise or physical activity, and 815 people with a musculoskeletal condition were surveyed to capture data on the barriers and facilitators to being active, so that behavioural diagnosis could be created. In addition, an ad hoc review of the literature was undertaken to understand the capability, opportunity, and motivational barriers and facilitators to physical activity for people with a musculoskeletal condition. That has since then been repeated as a structured review of systematic reviews, a rapid review of systematic reviews, which has recently been published, and I'll signpost you to that at the end of today's session, and that's supporting the ongoing evaluation of the programme, the wider physical activity programme. To further understand the target behaviour and possible intervention delivery options, conversations took place in late 2019 with 25 healthcare professionals involved in the design, development and delivery of services and activities for people with musculoskeletal conditions. That was then followed by 3 intervention development workshops held between November 2019 and February 2020, which I facilitated with members of the Versus Arthritis team. In attendance were a number of sections of the charity and sections of the organisation, so the digital partnerships team, or the digital team, the partnerships team, the health information teams. There were representation from people with arthritis, representation from Sport England, the arm length body that was funding this work and is responsible for getting people active in England. We worked through the stages of the behaviour change wheel in those intervention development workshops to design, develop and plan delivery of the intervention, which at that time we didn't know what it was going to be, but Let's Move with Leon came out of all of this work and these intervention development workshops. Finally, an advisory group of 41 stakeholders, including healthcare professionals, physical activity professionals, academics, patient representatives, was established to check and challenge the wider programme, but as part of that, obviously checked and challenged this intervention development process and the final intervention, and that group met on 3 occasions before the launch. There was obviously additional work that continued following those workshops by the teams at Versus Arthritis, the digital team, to develop what was really a starting point at the end of the second workshop of you know what the overall thing might look like, but then all of the detail in how it actually came together involved a huge amount of work from the Versus Arthritis digital team and other teams within the charity. As I say, London Met officially then became involved to evaluate the programme at the end of 2020. And our aim was to assess the reach and representativeness of the users of Let's Move with Leon during the COVID-19 pandemic and the restrictions that were in place. Furthermore, the evaluation aimed to examine the differences in physical activity, the capability, opportunity and motivation to be active of Let's Move with Leon participants at different stages of the programme. So could we look at the reach and representativeness of the users, but also how did physical activity differ by different stage? You know, if somebody was in week 1 or 2 compared to week 5 or 6 or compared to week 10 or 12, and also those components of behaviour. Did somebody's capability to be active, did they view that different in the first few weeks compared to the last few weeks, and the same with opportunity and motivation? So this was a service evaluation, the method. And this is a service evaluation defined by the National Research Ethics Service is an evaluation to understand how well a service is achieving its intended aims and benefiting service users, with the results informing future decision making. So this evaluation used secondary data collected by Versus Arthritis as part of service delivery, and the research team received the anonymised data, which was made available to us at London Met for the purposes of this service evaluation. So the service evaluation data was collected by Versus Arthritis from 26,041 users between the 16th of September and the 25th of February 2021. So 16th of September 2020 and the 25th of February 2021. So in that time, just over 26,000 participants signed up for this program. Data was collected at that sign up at program initiation on gender, year of birth, so we could determine age, ethnicity, musculoskeletal condition, levels of physical activity, how they heard about the program, and in addition, participants answered questions regarding their self-efficacy for individual development, their confidence in maintaining lifestyle change, the impact of their condition on daily life, their ability to lessen this impact, and the benefits or their beliefs of the benefits of lifestyle changes in relation to their condition and its management. In addition to these 26,000 users where we had that data at program initiation, Versus Arthritis also collected cross-sectional data from 2,752 participants across different stages of the program in February 2021. So the cross-sectional survey assessed levels of physical activity as the component of behaviour in the COMBI model, capability, opportunity, motivation equals behaviour. So it assessed the behaviour by measuring or asking people to determine their levels of physical activity. But it also collected data on people's physical and psychological capability, social and physical opportunity, and reflective and automatic motivation to be active. And here's just a sample of one of the questions on the screen that people were asked to rate. So I am physically able to change my behavior to improve my physical activity. What is physical capability? And the physical skill, strength, stamina to engage in the activity concerned. For example, I have the physical stamina, I can overcome disability, and I have sufficient physical skills. And then they rated that from strongly disagree to strongly agree. And then we collected that data to see if those components had changed. So to assess intervention reach and representativeness, participant characteristics were compared to national data sets where those data sets were available. The cross-sectional survey data was assessed for the relationship between program stage, week 1 to week 12. So it was looking at the relationship by program stage to physical activity and program stage to the COM-B component, the capability, opportunity, motivation component, using a regression analysis. An adjusted model was also run using the matched cross-sectional data and the participant sign-up data. So the 2,752 were matched to the sign-up data where it was available. So it wasn't available for all of them, unfortunately. But where it was available, it was matched, and then a regression analysis was run again, controlling for age, gender, ethnicity, and the sign-up scores for quality of life, the ability to achieve goals, the impact of the condition, ability to self-manage, perceive control over the condition, understanding of healthy lifestyles, and the ability to maintain physical activity in times of stress. So there's two models, one with the full 2,752 and the second one with matched data, the adjusted model, and the matched data was available for 495 of those cross-sectional participants. So let's take a look at the results. So I'm about to go into 6 slides, all with tables on them, lots of data, lots of figures. So being a physical activity program, if you're feeling like it's the end of the day and you need to stand up and wave your arms around, now is the time to do it. So you can then focus on these next 6 slides. Okay, so firstly, the reach and representativeness of this program. So I mentioned it's estimated that 18 million people in the UK have a musculoskeletal condition. Looking at those figures, if we had 26,041 participants sign up to Let's Move with Leon, that's 0.14% of the eligible population. Most Let's Move with Leon participants, nearly 60%, heard about the program through a Versus Arthritis communication channel. This isn't on the screen. So through a website or a publication or email or social media. And 36.34% heard about the program through adverts communicated through Facebook. So that was the biggest way they found out about the program. The reach of Let's Move with Leon promotional activity is not known. However, Versus Arthritis reports that they had 2.2 million interactions with people with a musculoskeletal condition in 2019. So using that as a crude figure, it's possible to calculate a crude reach of 1.18%. 2.2 million people, 26,041 participants. So now on screen, it's really about the representativeness. So the Let's Move with Leon users, participants were overrepresentative of females. So you can see there that the Let's Move with Leon data, and I'll explain the key so you can see some A, B's and C's that shows you or will tell you where the data's come from to compare against the national data set. So it's in a few slides time. I couldn't get the entire table on one slide, but you can see there that Let's Move with Leon, 91.01% were female compared to a UK population estimate of 55.85%. So there's a big difference there. But most of the participants were female. Most of the participants were white, and also of older age. There was little representation from those under the age of 35, just 1.2% of participants. And you can see that 97.47% of people classified selected the white ethnicity compared to a UK population estimate from the Office of National Statistics of 91.68%. The mean age of participants was 65 years, with 72% of participants being aged between 55 and 75 years. Again, not on the screen there, but you can see that it is over-representative of those aged 65 plus. 44.97% users were over 65 compared to a population estimate of 34%. Now, it was difficult to really categorize condition against a population estimate because, as you can see, 58.15% stated that they had multiple conditions. So the largest one was chronic joint pain, followed by osteoarthritis, but a huge amount of people have stated they had multiple conditions. So we couldn't draw estimates to UK level there. The users were more likely to be inactive than the population of people with a musculoskeletal condition. So 62% versus 44%. So 62% or 61.64, you can see at the bottom of the screen there, stated they were inactive compared to 44% from a UK population estimate. Now, it is noted that the way that physical activity was measured as part of this service evaluation data is different to the way it's measured in the UK population estimate, but it gives a kind of a broad understanding of the difference. So it's attracting inactive people. Again, this is just to highlight the type of people coming to the program. We couldn't draw comparisons to the UK population estimates, but people who have come to this program seem to have, in the main, a good or very good, or neither good nor poor quality of life. But it's still noted that just over a quarter had poor or very poor quality of life. In terms of the impact of the condition, in the main, it seemed to be moderate, but again, with over a third of people saying severe or very severe. So you can see where the data's come from. So the percentages are calculated from the data available. Missing data was excluded from those calculations, but I have outlined the missing data on these slides, and you can see it is reasonably significant. There was a high amount of missing data, which again, needs to be taken into consideration when reviewing these results. So, an 11 here in terms of quality of life, up to 5,556 in terms of physical activity state. So there is, a number of areas where data is missing. The estimates, where possible, were taken from versus arthritis data in terms of comparing those to the larger population of people with a musculoskeletal condition. The differences between ethnicities was based on Office of National Statistics and taking age standardized population estimates, and the physical activity data was taken from a versus arthritis survey. So this table reports on participants' self-efficacy for individual development, their confidence in maintaining lifestyle change, their knowledge and perceived benefits of lifestyle changes in relation to their condition and its management, and their ability to lessen the impact of their condition. This was data collected by Versus Arthritis at program initiation. So most Let's Move with Leon users at program initiation had a good understanding of how to make lifestyle changes to support condition management. So 87.27% said that they had a good understanding of what constitutes a healthy lifestyle, condition management. 87.7% had an understanding of what constitutes a healthy lifestyle. But it shows that participants were less likely to be confident in their ability to maintain a lifestyle in terms of times of stress, with only 41.69% saying that they agreed to that statement. Only 19.36 said that they could maintain lifestyles or achieve goals they set themselves, sorry. So again, much lower. That top statement there, only 19.36 agreed with that statement. So that just gives an understanding of the type of people that are coming to this program at the start. They don't believe that they can achieve their goals, but they have a good understanding of lifestyle changes. They know what contributes to a healthy lifestyle, but they may or may not be confident in maintaining lifestyle changes during times of stress. And often they feel, that, well, a third of people feel that they can't do anything to lessen their condition. So let's have a look at the results of the cross-sectional survey. So this is from the 2,752 participants sent out in February. And we've got the COM-B component there, the capability, opportunity, and motivation score. So let's start at the bottom. So at the bottom, we've got the key. So you can see that in yellow, we've got automatic motivation. So we can see that automatic motivation seemed to start in between 5 and 5.5 out of 10. But then tracked upwards and seemed people at different stages of the program. So it's difficult to say it increased for people because we're looking at different cohorts as a cross-sectional survey. But in terms of people at week 9 and 10, their automatic motivation was much higher than those at the start or hadn't actually started the program yet. When we look at the next line, the physical capability, again, we see that those at the start had a score out of 10 of between 5.5 and 6, and that seemed to track up for those in week 11 and 12 to above 6.5, dropping down a little bit for those at the end of the program. The next line up is social opportunity. So just to recap, automatic motivation is making things a habit. Physical capability, feeling physically capable to be active. Social opportunity, seeing things externally to them that from a social point of view that make them want to get involved in being active. This one started at 6 to 6.5, and then those at the end of the program seem to be just above 6.5. The next line up, the psychological capability, the knowledge of what to do, why you're doing it, the impact it can have. So tracked a bit higher for those at the start of the program, which can be confirmed from the slide before, between 6.5 and 7. For those towards the mid program, it got up to highs of about 7.5, and those at the end of the program just under 7.5. In orange, we've got physical opportunity. So that can be things like understanding what facilities are available, having the equipment. Tracks reasonably high for those at the start of the program. So people coming to this program already feel that they have a good understanding of the physical opportunities to be active, just under 7 out of 10, reaching a high in week 12 of just over 7.5. And then at the top, we've got reflective motivation, making the conscious decision to be active. So it starts as the highest, which we would probably expect. If people have joined this program, then they've reflected on their need to be active or to change their behavior and have joined the program. That stayed around the 7.5 mark for participants even at the end of the program. So we can see that the differences there in the COM-B components at different stages of the program. People were combined into those not started. If they were in week 1 or 2, they were put into a group, week 3 and 4, 5 and 6, etc. So what did the regression analysis tell us? So an unadjusted regression analysis suggested small but significant improvements across all components of behavior as the program stage increased. So these significant findings remained unchanged in the adjusted model, with the exception of social opportunity, which didn't see a significant increase. The regression analysis indicated that physical activity increased as program stage increased in both the unadjusted and adjusted models. So just to recap, the adjusted model controlled for age, gender, ethnicity, and program sign-up scores for quality of life. the ability to achieve goals, impact of condition, ability to self-manage, perceive control over condition, their understanding of healthy lifestyles, and the ability to maintain physical activity in times of stress. Regular physical activity was defined as 150 minutes of moderate or intensity activity each week. And again, as I mentioned before, we grouped people into 8 groups, 8 buckets. So 1 being not signed up, group 2 in weeks 1 and 2, group 3, weeks 3 and 4, 4, 5 and 6, and so on, to group 8 who are at the end of the program. So let's discuss those findings. So we set out to evaluate a digital intervention to improve physical activity delivered during the COVID-19 pandemic. It was called Let's Move with Leon, and we assessed it for its reach and representativeness of participants to the UK population and its potential benefits for physical activity and the components of behaviour. Just to recap again, an evidence-based approach was taken to the development of Let's Move with Leon, first understanding the behaviour of physical activity before using the behaviour change wheel to design the intervention. The development involved over 100 people with an MSK, musculoskeletal condition, and 66 professionals. A large number of people with a musculoskeletal condition in the UK signed up to Let's Move with Leon during the COVID-19 pandemic between September 2020 and February 2021, over 26,000 people. However, large amounts of missing data at programme sign up, with up to 21.34% missing data depending on the question. From the data that we have available, it suggested that users of Let's Move with Leon are most likely to be aged over 55, or between 55 and 75 years, 72% of participants, be female, 91% of participants, white, 97% of users, with a chronic joint pain, 84% of users, with their condition having a moderate to severe impact on their daily life, 85%, with a moderate to good quality of life, 73%. At program initiation, users are most likely to be inactive, 61%, with a good understanding of what contributes to a healthy lifestyle, 88%, and with the knowledge that lifestyle changes could improve their condition, 87%. So whilst the profile of those that signed up to Let's Move with Leon is not representative of the broader population of people with a musculoskeletal condition in the UK, that's not to be unexpected, as behaviour change interventions are never, or very rarely, one size fits all. So it can be designed, but then you don't know who's actually, when you're marketing or promoting these services, who's going to come. That said, action should be taken to investigate, and one of our recommendations was to investigate the underrepresentation of users from other ethnic groups other than white, from males and also from the younger population. The participants that attended Let's Move with Leon may represent those that are more likely to engage with the digital intervention during times when a period of restrictions to the movement of people are in place. But it's probable that they also represent those that are more likely to engage with the charity. Advertising through Facebook seems to be effective at engaging participants in this particular intervention, with 36.34% of participants coming through that route. So in terms of possible outcomes, the behavioural components of reflective and automatic motivation, physical and psychological capability, and the physical opportunity increased as program stage increased. Interventions which encourage engagement stand the best chance of success. However, increasing social opportunities in an online setting is obviously challenging. What I've not mentioned yet is the Facebook group. So Let's Move with Leon directed users to a Facebook group, which had, when we conducted the evaluation, 7,476 members, suggesting that only 28% of Let's Move with Leon participants made use of that group. So that may explain why some of the scores for social opportunities didn't increase as program stage increased. It's noted that reflective motivation scores reported from the cross-sectional participants yet to start the program were already quite high, it's 7.28%, suggesting that people drawn to the programme were already motivated to make a change despite lockdown measures and social movement restrictions. The chance of participants being regularly active increased by programme stage, suggesting that Let's Move Willie On improved physical activity in participants during a time of restricted social movement resulting from the COVID-19 pandemic. Now, I do say all these findings with caution. It's a cross-sectional survey data with match data for only, nearly just under a quarter, not even a quarter, sorry, a fifth. So caution is advised in the interpretation of the cross-sectional data, as it only shows associations and group differences, not causation. So in conclusion to this evaluation, the data presented in this paper was collected during the COVID-19 pandemic, and that included 3 UK national stay-at-home orders with varying degrees of restrictions in movement. It is a unique situation. There was little evidence against which to compare or against which comparisons can be drawn. It suggested that engagement with online physical activity programs increased during lockdown, with numbers decreasing afterwards. Some Sport England data suggested that, and there's also some studies from Germany that suggested that. It may be that digital programs only reach particular population groups at these sorts of times. For example, there was an overrepresentation of female users, and that has also been reported in other studies, or 2 other studies. The findings reported in this paper, this evaluation, should be considered in future digital program evaluations to enhance understanding of the reach and impact of similar programs. It's in the national interest to do so, and this is highlighted by the UK Parliamentary Committee to explore the impact of digital technologies on physical activity. The data that we had available would suggest that Let's Move with Leon, which was designed to improve physical activity, could be impactful during measures to restrict movement and to slow the spread of infectious disease in those that are already motivated to become or stay active. So I just very quickly want to tell you, what's so now that the measures in the UK have eased, intervention analysis should continue to identify those that are currently engaging and those currently not engaging with the programme, to understand its use and its impact. We are now moving into the next phase, or we've just come to the end of that phase, where we conducted a randomised control trial and qualitative evaluation to, against a control group, understand the impact of Let's Move with Leon on physical activity. COMBI is the primary outcome, with the secondary outcomes of its impact on health-related quality of life, which wasn't evaluated in this service evaluation, but also the COMBI components, with a measure, an objective measure where people were asked to use their phones to monitor their steps every week for 13 weeks, and also a survey on sitting time. So we've got a randomized control trial, 195-ish, I think it's 195, 194 in each group, one getting the intervention, one just getting the surveys every week. Physical activity is the primary outcome, self-reported, with, for those that could, an objective measure of steps using their phones, sitting time, and health-related quality of life and COMBI component as the secondary outcomes. So that's ongoing. So it's a registered trial, registered with the ISRC-TN registry, an evaluation of the effects of a digital web-based intervention on physical activity of people with a musculoskeletal condition. We had 2,836 express an interest in this study, 541 provided consent, 389 provided complete baseline data, which we then split to receive Let's Move Willie On of the survey. We did have, we're coming to the end of this now, a number of withdrawals. So we had 9 withdrawals in the control group, 6 due to ill health, 3 due to joint replacements, and 11 in the intervention group, 7 due to ill health, 2 due to joint replacements, and 1 due to digital literacy, and 1 no longer interested. So their data was removed. And there's just a recap of the measures that we're collecting that I've already spoken through. In terms of the qualitative evaluation, so where are we at the moment with this? So you can see it says weeks 1 through 13 here. We've collected that data and we're analysing that data. The analysis is done on that data. We're pulling together the presentation of that. The 6-month data is still being collected because we had two groups, 2 rounds of recruitment. In terms of the qualitative evaluation, we had 11 interviews take place and we had 674 survey comments where people could just, we didn't ask any particular question, we just said, if there's anything you'd like us to know, please type it in. Every week they could do that. So across the 13 weeks in the intervention group, we had 674 comments which have been involved in the analysis. The publications that have come from this work so far, the publication that I've presented to you today is up, available for you to read. There's the title, The Reaching Benefits of a Digital Intervention to Improve Physical Activity in People with a Musculoskeletal Condition, delivered during the COVID-19 pandemic in the UK. But I also mentioned the literature review, which was then repeated to support this evaluation. That has just been published. The barriers and facilitators to physical activity in people with a musculoskeletal condition, a rapid review of reviews in the COMBI model to support intervention development. If there are any students here who are doing dissertations around literature reviews, you might want to look at the methods section of this because it might help you with the development of your own dissertation. So I'm just coming to a close now. People I need to thank and acknowledge. So my co-authors, Rhiann Horlock, Ashley Alquist, Amelia Hall and Karina Brisby from Versus Arthritis, and Stephen Hills and Duncan Stewart from London Met. Also like to thank stakeholders involved in the development and delivery of Let's Move Really On. Particular thanks go to the Versus Arthritis digital team, Bryony Milosevic, and also to Leon and to his mother Janet, who are the face of Let's Move Really On and actually helped develop the programme as well. I should also thank those that were involved in the subsequent work. So Anna Baker, Tiffany Palmer, Jenny Darlow, Victoria Alanian, and Versus Arthritis, Rhiann Horlock, already mentioned, Amelia Hall and Ashley Alquist, already mentioned, who were involved in the literature review that's recently been published, and also Duncan Stewart from London Met. And finally, I'd like to mention Heather Allison and Michael Mapra, who are conducting the qualitative evaluation. So Heather conducted the interviews I briefly mentioned, and Michael is analysing the 674 qualitative comments. So I just wanted to mention them because they're part of this broader evaluation. This work was funded by Versus Arthritis through a national lottery grant from Sport England. And just for the recording and for the slides, here are some selected references based on some of the things that I've mentioned today around prevalence of musculoskeletal conditions, the impact it can have, physical activity can have, using the behaviour change wheel, how we develop the survey measures around COMBI, and then some of the information about the use of digital media during COVID-19. So there's my details on the screen there. Do get in touch if you have any particular questions for me. My email address is there, my ResearchGate profile is there. So I'll now open up for questions. I will come back to the slides here. Great. So what I'll do, I've heard some comments coming in. So let's have a quick look. Yeah, Graham. So interesting that physical capability drops towards the end of the program. What we've noticed from the randomized control trial is that physical activity, particularly, not just the components, it goes up and down across all of the weeks, and it's very rarely this, what we would, everybody wants this kind of nice linear increase, but it doesn't happen, and it seems that people talk of episodes where they're experiencing particular pain or are feeling incredibly fatigued. And it seems that physical capability is one of the key things from the qualitative evaluation that really impacts people's engagement with the program. if they didn't feel physically capable, then they didn't engage with the program and actually felt like they kind of dropped off a bit, and it was struggling to get them back in. But yeah, it is interesting from this evaluation how it drops off. I should note that those at the end of the program, this went out to all participants, so some of them might well have been 1 week at the end of the program. Some of them might have been 6 weeks, 6, 7 weeks at the end of the program. So that might be another reason. Regina, can you get a copy of the presentation? I understand that this is being uploaded to YouTube. I'm happy to send out these slides to anybody that wants it. So I will, let me just go back a slide. There we go. So if you do want to drop me an email, I'm happy to send the slides to you. That's no problem. Another question, is it possible to provide an attendance certificate, please, PhD student, and we need to certify for our education credits, and thanks again. Potentially, I would contact so it's the Centre for Primary Health and Social Care that are hosting today. So you might want to contact Yolanda, or send me an email and I'll forward it on to see if the centre can provide you with that. So is there a reason why physical opportunity so decreased at the end of the program? My thoughts about physical opportunity decreasing at the end of the program, it could be because the program's ended. So physical opportunity would be, seeing physical opportunities to be active. Facilities could be the program itself. It's a physical opportunity to be active. The fact that it's ended would automatically then reduce one of the opportunities that people have to be active unless they went back and repeated some of the activities. So that is potentially one reason why physical opportunity decreased. Also, we were in a period of lockdown, so as that program ended, there may not have been a number of facilities going on. Looking at the RCT and the qualitative evaluation we've got going on at the moment, I don't want to talk too much about those findings because we will be presenting those at a later date. But again, some of the qualitative feedback is, this particular local activity I used to do is no longer happening and it hasn't started again. So I think it's probably a combination of the program ending, but also a lack of facilities and not starting again once this program has ended. I think I've got through all of the text comments. So please do turn your mic on if anybody else here has any other comments. Duncan.
Hi, Justin. Thanks for your presentation. This is because I'm part of the, well, you do all the work. I'm part of the team. And on that note, I just wondered, in terms of the experience of doing a study like this for an organisation like Versus Arthritis, what have been the main challenges of actually getting the research done?
The biggest challenges, I think, the biggest challenge was the start of the program. So we came with a proposal of how we would run the research. And the proposal changed as we spoke to the charity and as we worked together as a team. And I think that was one important thing, is that we worked together as a team on this. And because of the pandemic, we changed some of the protocol. So originally we were going to send wrist-based pedometers to a small selection of participants, and we went back and forward about doing that. We would be sending, we would be buying wrist-based pedometers and sending them to, I think we said sort of 50 in each group at week 1 or baseline, and again at week 13. And then it wasn't a challenge, it was just time consuming because we had the conversations with the charity about how we might do it better. And then we decided to use mobile phones and looked at the research around the use of mobile phones to collect step data. And yes, there's always going to be bias in that, but we thought actually it gives us a bigger opportunity to monitor steps every week for 13 weeks from a much larger group of participants. Now, I appreciate that's probably going to bring bias into to the work. I'm talking now about the RCT, sorry, not this particular work. This is phase 2, just because I'm working on that at the moment. But I will come back to the challenges for this work. So, you know, it was actually getting the protocol signed off, confirmed, and then having particular timeframes. We wanted to recruit 700 to the RCT. We've only recruited 4. So we had 2 rounds of recruitment, and that knocked everything back. And obviously there are deadlines to hit. So it's just managing milestones and deadlines, I think, was the challenge. In terms of this particular work, it was dealing with how can we get the best of what data we had, and how can we really tell a story that we think is accurate from the data that we had. So large amounts of missing data, but also 26,000 people. So a huge amount of data. We had, you know, there was the opportunity, which we did get ethical approval for, to work with the first authorities to get the cross-sectional survey out. So we designed that and asked them to send it as part of the service evaluation. That really helped. They've been fantastic to work with. They've been open to suggestions, and I think actually it's quite brave of an organisation to open themselves up to an independent evaluation, because we might say things don't work, and they've invested time and money in this program, but if things don't work, you know, you learn from these opportunities and from research, so things can change and money's better spent in the future. Graham.
Yes, thanks, Justin, for a comprehensive, informative seminar this afternoon. One of the things I was thinking while you were talking was, in terms of the demographic that the campaign attracted. I mean, you talked about inactive Caucasian females who were digitally active during the pandemic. I just wondering what your thoughts are about a health promotion campaign that what might be needed to increase the kind of gender balance in responses. Have you given any thought to that?
Yeah, my thought is from an intervention development point of view, from my experience of designing interventions previously, the people you design it with the best will in the world, and you get views of from a broad selection of people, you know, trying to be representative, get representative views from the UK population of people with a musculoskeletal condition, which Versus Arthritis did in this instance with a survey of 815 people going out to a representative sample. But once it's launched, in this case, you know, it was launched before the RCT happened because of the pandemic. You don't really know who it's going to attract. So I think to address that issue, I think it's about going back to the drawing board again and saying, okay, well, who doesn't come? Let's get some data and understand physical activity in those groups, people with a musculoskeletal condition who aren't white, you know, who aren't female, who aren't of considered older age, or 55, 60 plus, or 75 plus, and ask them, you know, what are the barriers and facilitators to being active, but also what are the barriers and facilitators to digital programs, and what is it you need, and then additional interventions can be designed. What we have done as part of the literature review is we've created a checklist for intervention designers going forward of all of the barriers and facilitators split by COM-B component. But at the bottom, we've also included information of underrepresented groups who need to be considered, because potentially you could be increasing health inequalities. In this instance, females generally are shown to be less active than males, so you know, it could be argued you're reducing that health inequality, but equally you could be increasing health inequality because people from certain ethnic groups are less likely to be active than others. So we've created this checklist, which the charity have actually implemented to all of the people they fund to deliver programs, to go through and think, which barriers am I overcoming, which facilitators am I enhancing, and have I considered the needs of all of these groups that are more likely to be inactive, and that's things that aren't covered today, like socioeconomic status as well, levels of education.
Okay, thanks, Justin. I guess that question or that challenge is another piece of work, isn't it?
Yeah, it is another piece of work. The difficulty is when you're evaluating this qualitatively, from the work we're doing at the moment, we're talking to people that are participants. So if we're asking the question why to them, why do you think this is the case? Well, they're the ones that have been attracted. They're not the people. We need to be talking to the ones that aren't coming. So that's the next piece. Well, potentially the next piece of work.
Okay, thanks very much, Justin. It's a really interesting seminar. Thank you.
Okay, I don't know if there are any more questions. I think what might be an idea is I'll stay on the line. I'll turn my camera off. I'll leave my details on the screen, and then if any questions do come in, or if people want to talk, I'll just make sure I'm still around. But I don't want to keep people unnecessarily. So unless there are any other questions, thanks for attending. I'll turn my mic off and my camera on, but I will stay here for 10 minutes or so in case any questions do come in.